Vertigo is a descriptive clinical term referring to a sensation of movement between a person and their surroundings. This sensation is usually horizontal and may resemble the feeling of disorientation following an abruptly stopping after spinning around a swing. Vertigo is frequently accompanied by symptoms such as nausea, vomiting, sweating, and a general feeling of being unwell. Although vertigo itself is not a diagnosis, it is a symptom that can arise from a wide variety of underlying conditions. A comprehensive understanding of these causes and mechanisms is essential for proper diagnosis and management. Now let's talk about the pathophysiology of vertigo. Balance and spatial orientation are maintained through the integration of three major sensory systems: the visual inputs, the proprioceptive inputs, and the vestibular inputs. The visual inputs from the eyes helps to detect position and movement in relation to the environment, while the proprioceptive inputs from the muscles and the joints helps to provide information about the body's position, while the vestibular inputs from the inner ear detects motion, equilibrium, and spatial orientation. Vertigo arises when there is a mismatch between these sensory inputs, especially when the vestibular input disagrees with the visual and the proprioceptive signals. The vestibular system located in the inner ear is the most important structure to understand when studying vertigo. The vestibular apparatus contains three semicircular canals, each positioned in different planes to detect different type of head movements. These canals are filled with fluids called endolymph. When the head moves, the endolymph shifts and stimulates tiny hair-like structures called stereocilia, which are located in the ampulla. These hair cells generate impulses that are transmitted via the vestibular nerve to the vestibular nucleus in the brainstem and to the cerebellum. The vestibular nucleus relays information to the eye movement control center, the thalamus, the spinal cord, and the cerebellum. This complex coordination enables the body to maintain balance and stabilize visual movement. Next, let's talk about the causes of vertigo. Vertigo can be characterized based on whether the problem originates from the peripheral vestibular system or the central nervous system. For the peripheral causes of vertigo, we have number one, the benign paroxysmal positional vertigo, which is BPPV. The benign paroxysmal positional vertigo is caused by dislodged calcium carbonate crystals known as autoconia that migrate into the semicircular canals. This movement disrupts the normal flow of endolymphs and overstimulates the sensory receptors. Patients typically experience a brief episodes of vertigo that are triggered by changes in head position, such as turning in bed or looking upward. The vertigo usually lasts less than a minute and resolves when the head is kept still. There is no associated symptoms like hearing loss or tinnitus, and patients often report that the vertigo comes in episodes over several weeks before subsiding, although it may reoccur months later. The condition is often diagnosed using the Halpic maneuver, which involves moving the patient into a specific position to provoke vertigo and observe characteristic nystagmus. Then, the second in the peripheral causes is the Meniere's disease. Meniere's disease is believed to result from excessive accumulation of endolymph in the semicircular canals, leading to increased pressure and disruptive vestibular signals. Patient typically presents with episodes of vertigo that last several hours. These conditions are associated with sensorineural hearing loss, tinnitus, and a sensation of fullness in the affected ear. The vertigo is triggered by positional changes. Over time, the hearing loss often worsens progressively, even between attacks. During an episode, patient may exhibit spontaneous nystagmus, where the eyes are rhythmically moving without intentional movement. Menial disease is diagnosed based on clinical criteria, which include 2 or more episodes of spontaneous vertigo lasting at least 20 minutes, documented hearing loss, and associated tinnitus or aerial fullness. Number 3 on the peripheral causes is vestibular neuritis. Vestibular neuritis is an inflammation of the vestibular nerve, usually caused by a viral infection, although it can occur without other signs of viral infection. The condition is typically present with a sudden onset of intense vertigo that lasts for several days to weeks. Unlike Menial's disease, it is not associated with hearing loss. The vertigo is constant and often accompanied by unsteadiness and nausea. Vestibular neuritis is diagnosed clinically based on the history of acute prolonged vertigo without auditory symptoms. So, neurological examinations may reveal spontaneous unidirectional horizontal nystagmus and positive head impulse tests. Other peripheral causes include vestibular nerve trauma, acoustic neuromas, osteochlorosis, otosclerosis, hyperviscosity syndrome, and the Erasmus-Hunt syndrome. Now let's talk about the central causes of vertigo. Central vertigo originates from abnormalities in the brainstem or the cerebellum, where the vestibular signals are processed and integrated. The first one we have posterior circulation infarction, which is also called stroke. This is the most common critical central cause, and it includes disruption of blood flow to the cerebellum and brainstem. Patients often experience a sudden onset of vertigo, which may be accompanied by ataxia, which is impaired coordination, or diplopia, which is double vision. It is also accompanied by cranial nerve deficit or limb weakness. The vertigo is usually sustained and not positional. For the diagnostics, a high index of suspicion is necessary. MRI of the brain with diffusion-weighted imaging is gold standard for detecting. Then, number 2 on the central causes is brainstem or cerebellar tumors. Tumors in these regions causes gradual damage to the vestibular pathways. Patients may report progressive vertigo which worsens over time. Other symptoms may include headache, unsteadiness, and signs of increased intracranial pressure, such as nausea or vomiting. For the diagnosis is made using brain imaging such as CT or MRI scan to prevail the presence of the tumor and locate the tumor. Then, number 3 on the central cause is multiple sclerosis, also called MS. Multiple sclerosis can affect the brainstem or the cerebellum, leading to vertigo. Vertigo in multiple sclerosis usually occurs as part of the relapsing remitting pattern. It is often accompanied by other neurological symptoms such as optic neuritis, visual disturbance, and numbness or weakness in various parts of the body. Multiple sclerosis is diagnosed using a combination of clinical findings, MRI evidence of the myelinated lesions, and sometimes cerebrospinal fluid analysis. Now, number 4 on the central cause is the vestibular migraine. Vestibular migraine is a subtype of migraine disorder in which vertigo is a predominant feature. In clinical presentation, patients experience episodes of vertigo that last from several minutes to hours, often associated with visual aura, photophobia, phonophobia, or migraine headache. Unlike BPPV, the vertigo is not positionally triggered.